Janae Sharp, and I'm sitting down here today to talk with Dr. Sinopoli. I'm looking forward to this because we got to hear from Dr. Reardon last time, and he talked about value-based care and about being able to coordinate between care teams and practice at the top of your license. So I would love to hear what you have to say about it and more about your background, because for those of you watching, Dr. Sinopoli has kind of an awesome career background. He's worked with Centers for Medicaid Innovation, like, you know, a lot. And I feel like people need that knowledge. So if you want to tell us about that, that'd be awesome.
Sure. So thank you, and I appreciate the opportunity today. So yes, I am a pulmonary critical care physician by training, but I've spent the last 15 years or so of my career actively involved in value-based care, population health. And more recently, before I came to Upstream, which we'll talk about in a few minutes, I worked for an integrated delivery system called Prisma Health in South Carolina. I was the chief clinical officer there, facilitated the merger of the Greenville Health System in the upper part of South Carolina and Palmetto Health System in the Midlands of South Carolina into a single integrated delivery system called Prisma Health. And in that role was responsible for many of the clinical functions, the physician practice group, et cetera, but also in the upstate of South Carolina, built the clinically integrated network from scratch. And then as we merged those two networks into one large network, which in total comprised about 5,000 providers across the network, which made it a fairly large network. And we had 320,000 patients at some kind of alternative payment model risk arrangement across all product lines, including MSSP, Medicare Advantage, commercial, direct to employer, Medicaid. So a fairly broad experience there. And one of the things that I realized immediately as we were building the network is that we really needed the expertise to drive the success of the network, and built a separate freestanding company called the Care Coordination Institute, which is where we housed our data and analytics, our care management teams, our process improvement teams, our population health teams. And we did that to isolate them away from the daily urgencies of the delivery system so that they could wake up every morning focused on the needs of the network and the patients within our value-based products. And that worked pretty well. The other pieces of my experience is that I've been very active nationally doing consulting work for other clinically integrated networks, but I also was one of the original members of the CMS Land Guiding Committee, and been on that committee for about 6 years. Have been on the Physicians Technical Advisory Committee for CMMI for now about 4 years, and have really enjoyed that work. And I've been on multiple other committees over the years: Healthcare Transformation Task Force, Board of Directors for America's Physician Groups, et cetera. And so I just say all that to demonstrate my passion for alternative payment models, population health, and the time and effort that I've put into it over the years. So
yes, you've really dedicated a lot to it. I think it's interesting speaking to different people in the industry about that. You know, they've been talking about value-based care, about moving. This idea that we're not paying people for improving health is not new. You know, you've been around since people started talking about that. And I think it's always interesting to ask people a little bit about that disconnect. Like, obviously we want people to be reimbursed for the work they do, and we want people, physicians, clinicians, healthcare delivery systems, to be able to improve the population health, improve the health of the people that they're helping. And sometimes that doesn't happen. So I'd love to kind of hear your unique perspective about that gap. Like, why is the technology so cumbersome? Why is it so slow? Why haven't, you know, adopting these payment models? We've been hearing about that for years, you know,
Yes.
people talk about it. You hear about different theories. You hear people say, oh, you got to be scared of that. You know, I've heard a lot. So I'd love to hear your perspective about why that is. Like, why is this so hard for people? I've asked a lot of people that. I'm like, so if it's so good, why is it so slow?
Good question. And you hit the nail on the head. So, you know, our entire healthcare system today is built around the fee-for-service model. Mm-hmm. Delivery systems, physicians are used to that. You know, and let me create a widget and let me get paid for it. It's clean and simple. All the business models and all the technology have been built around that model. EMRs, which should be helpful to us in being able to evaluate our patient populations and what our patients need. They're really documentation instruments and billing instruments, and they're really built for what I call last year's business. Okay.
Yes.
They're
good at last year's business.
They're good at last year's business, yes. And so they really don't provide the technology and the insight we need to manage today's risk arrangements in healthcare, and don't give us the kind of insight into our patient populations we need to make the kind of population health decisions we need to make. And what I've recognized working in our network, working in other networks, you know, being on these committees that are trying to figure out how as a nation do we drive value-based care across the country. And what I've realized is there's a number of barriers that stop that. And unfortunately, it's not just one simple fix. It is a number of things. And so one of the first barriers is that physicians and even delivery systems are unwilling, unable to take significant downside risks today. I mean, if you think about a 2 or 4 man physician practice and tell him he's got to go at downside risk and put up $1 million worth of risk, to do that, it's just unfeasible. Even delivery systems are have to adhere to quarterly budgets, and if they take too much.
Maybe you could quantify that a little bit, because you're saying take $1 million of risk. People don't make like $1 million a year on a patient, right? Like, what does that, like, that's a huge amount of money when you kind of look at those contracts, but I don't really understand. What does that even mean?
So it's a good question. So as a practicing physician, you know, you make your living in today's world off of E&M visits. Okay, as you see patients, you're billing for that individual visit. Okay, when you move to what's called global risk, where you're taking risk for that entire patient's care, then that grows beyond your little income stream to what could be millions of dollars that would be spent on the population's healthcare, including their emergency room visits, their office visits, their radiology interventions, laboratory studies. All those things then become aggregated into that dollar amount. And so for a individual physician to say, oh yeah, I'm willing to take risk for all that, when there's not a proven model and he doesn't have the financial backing to do that, is a huge barrier. And so, and even for big delivery systems that have certainly deeper pockets to be able to do that, they're worried about their bond rating. They're worried about other things, because now on their books they have a risk of what could be $100 million in their case, because they're taking risk for maybe several 100,000 patients.
Right.
And so so that's a huge barrier. And when you can't take that downside risk, you can't access enough upside potential to make an alternative payment model worthwhile. And if you're only going to share in a couple of percent savings, then it's just not worthwhile.
Yeah.
If you don't have enough patient volume is the other barrier. And so practices that do a little bit of alternative payment model care where they may only have a few thousand patients involved in it, it's not a big enough percentage of their practice to really redirect how they work day in and day out.
Mm-hmm.
The other barrier is that to make these models work, you've got to have expertise. And you can't expect
You have to know how to improve health.
You have to know how to improve health. Exactly. And you can't rely on your office nurse or just hiring an extra body in the office to really understand how to drive all of those outcomes. And that expertise nowadays is fairly expensive. And so most practices or even delivery systems, again, we're talking about investments of millions of dollars to hire those people up front, not knowing if you're going to get a return on investment down the road. Okay.
Mm-hmm.
So that's another barrier to it. And then the last barrier is in the models today, the way it works is you go at risk for a patient population. The doctors work all year. They sometimes have very unclear line of sight in terms of how well they're doing. And then at the end of the year, the contract closes and they wait 8 or 9 months to find out whether they did well or not and whether they're going to get any shared savings or not.
Well,
And
people
so,
are really good at delayed gratifications.
yeah, exactly. A huge delayed gratification. And so that just doesn't incentivize the practices to function differently very well in that model. And so what's really needed is a model where the doctors are seeing instant gratification. And so as they're driving quality and driving improved patient care, that they can see it both clinically and they can see it financially, that they are making strides and they are going to be able to cover their investments and their staff they've hired and et cetera, and not have to wait 18 months to see if they've broken even or not. So all those are barriers that have to be addressed.
Yeah. So I like that they're rewarding people for giving good care, they being upstream, right? So I would love to hear more about them, like about why you have this broad background. Why did you choose that?
Yeah, so good question. So I am now the Chief Network Officer for Upstream and have been so since last February. And when Upstream,
congratulations.
Thank you. I've really enjoyed being here. And when Upstream called me and described their model, and I had heard bits and pieces about it prior to them calling me, but as I heard their model, I thought, gosh, that solves all the barriers that I've run into over the years. And so the Upstream model is a model in which Upstream takes all that downside risk. Mm-hmm. They move contracts into global risk arrangements, including REACH, which is the new governmental program. We partner with Medicare Advantage programs to do global risk. But Upstream takes that downside risk off the doctors and off the delivery systems. So they don't have to worry about that anymore. And then we do 2 other things that really enables us to take that risk. One is that we embed clinical teams within the primary care practices. We think primary care is really the key to driving these ultimate outcomes, not in isolation, but they are the most important key. And as long as they're connected to the other parts of the delivery system and the care model across the community, that is an area where, with what we call linear integrity, where we always are connecting back to the primary care doctor, we're driving those outcomes. And we embed clinical pharmacists and clinical care teams within the practice itself. They identify those high-risk patients that we know are driving cost and are driving poor quality outcomes. And those clinical teams will meet face-to-face with those patients and really help manage their care, working with the primary care doctor to identify their risk, to close their gaps, to identify their social determinants of health risk, make sure they've got transportation, all those things. But it's not telephonic from 1,000 miles away. It's a known provider that those patients develop relationships with. they trust, they know that they're acting on behalf of the doctor that they're seeing, and it's their primary care doctor. And so we have found that that model works really well.
I like that. I'd love to talk a little bit more about that, like share
Yeah.
why primary care. Like I have a lot of feelings about that, and I think it's interesting to see the way payments are structured, and also like the most expensive things aren't always taken care of by a primary care doctor, but you're investing there. So maybe you could talk about, I mean, why?
Yeah. So if primary care is utilized in the way it should be, so primary care practices are making sure that those patients are coming in and being seen. Even the low risk patients, we try to make sure those patients are coming in and being seen at least once a year. That's an opportunity to document all the issues that are occurring with that patient, to identify whether they've got, a rising risk, as we call it, whether they're developing diabetes, where, what their needs are. If it's an opportunity to get to know their social situation, their family support mechanisms, their transportation abilities, et cetera. And so as we do that, and particularly as we identify those patients that have multiple chronic diseases that need more intervention, then in that environment, we can intervene very early and stop those ER visits and stop those interventions that are unnecessary, stop the progression of their diabetes, stop the progression of their heart disease, and really create a significant bend in the cost curve, so to speak. And what we have found is that in those patients that we're actually intensively managing, to the end of 12 months, we've driven hospitalization rates down by at least 45%.
That's
And
huge.
so it's huge. It's huge.
Huge.
And the difference between that on-site relationship management, the on-site care management, and telephonic care management is night and day.
Yeah.
And so that's really what drives the outcomes, is that relationship.
That's so your CEO, the Upstream CEO, recently spoke about the importance for that, like how now is the time to invest in primary care physicians, and that it's a perfect storm for the need.
Yes.
And like just the amount of money you have to float for some of that stuff means, we're losing people's health because we didn't have the money to,
Right.
go before it was an emergency. I'd love to hear more about your opinion on that. Like, what does that mean? The perfect storm with need with, investment, technology. This is a lot of stuff. Like, we've already done a lot of money investing. Like, we need to do more. Let's.
Well, I think the money that needs to be invested in the right places. And I think, so I'm a pulmonary critical care physician, and so I can tell you as a specialist, I can say this as a specialist, that specialists are extremely important in the care model itself. But in the past, we have not focused on primary care as really the center of care for those patients. And we've spent a lot of money developing technology, a lot of money developing specialty care, but not a lot on primary care and primary care prevention. And that's really where it needs to move. And in defense, what's happened is that, again, getting back to the EMR, the doctors have had very little technology support and understanding what their patients needed. And so until EMRs change, what typically has to happen is that we have our own data analytics platform that we can plug into the practice's EMR and extract clinical data. We can extract payment data, claims data from the insurance companies, combine all that, and we can get a very clear picture of what those patients' risks are and who is most likely to have to come to the emergency room and most likely to have an intervention, and we can intervene early. We also have technology that connects to the hospitals and the emergency rooms, that if those patients show up, we get an automatic notification. So we know in real time what's happening to that patient across the continuum, and we can intervene real time. primary care practices have not had that kind of information and data before. And it's mostly, Ms. Smith shows back up for her follow-up care and describes to the primary care doctor, well, I've been to the emergency room 3 times and I've been admitted once and I've had all this stuff done. And he's had no ability to intervene during that time.
Right.
So I think the
Out of
technology,
sight, out of mind sometimes.
out of sight, out of mind in both directions. So I think the new technology platforms that are evolving are going to help solve some of that problem.
Yeah. I like what you say about how, electronic health records are great at managing last year's business. Earlier today, a lot of people have spoken about how important it is to get the right tools for the people providing care. And we know that healthcare has had a lot of people quit lately.
Yeah.
Enough, they're calling it a great resignation. Massive structural changes have been necessary. We see people who are posting billion-dollar losses.
Yeah. I think particularly for physicians, as you know, as well, there's been a huge physician burnout over the last couple of years. The stresses of COVID, the stresses of trying to manage a practice and to break even. And unfortunately, it's a reflection of, again, last year's business model for medicine. And it's been very much a hamster wheel of, I've got to see more patients today. I've got to work patients in. I've got a fee for service model where I don't get paid unless I'm seeing a patient and actually intervening and doing something to them. That model needs to change. And the advantage of these alternative payment models, particularly if you're taking global risk, is that you do have more time to spend with your patients. It's not about creating a hamster wheel. It's about creating outcomes. And it's also about partnering with teams. And so the teams are doing a lot of the work, and the physician then becomes the captain of the ship and is driving the strategy and driving the needs of the patients being met. But that team is taking a lot of that day-to-day workload off the physician and giving him time to function more as a physician and not stuck in that hamster wheel.
I like that.
What we've seen is that our docs and our model have been more productive. They've been happier. They're getting home on time. They're actually covering more patients than they were before. But they've got this expert team that's helping create that model for them.
Yeah. I think too, we talk about practicing at the top of your license and how it makes sense. Like, physicians didn't go into medicine so they could learn how to type.
Right.
Which is lucky because some of them are really bad at it. With your support that you have and the current state, what does it mean to practice at the top of your license when you're understaffed? Mm-hmm. Basically, is it that Upstream comes in and they have extra people, or what is it that helps?
So it's a combination of things. It is extra people. They're doing a lot of extra work, but it's also what they're focused on. And so what it allows the doctors to do is to free themselves up to do what doctors do. As you talk to any doctor today, they'll tell you they spend an inordinate amount of time signing off on pre-authorizations and pre-certifications and dealing with pharmacy calls and insurance calls and all kind of administrative stuff that you were mentioning. And it eats up a lot of their time, and it's non-rewarding time. This team takes—
What? People don't love talking to the insurance companies?
Yeah, can you imagine? Yeah.
Never heard that.
So this team takes that burden off the doctor. They take all those pre-auth calls and pre-cert calls and calls from the pharmacies and insurance companies. And since it's a clinical pharmacist, they can handle a lot of those calls and work with the physician. Now the physician's free to do clinical work, to spend time in an exam room, to talk to a patient and the family, and then they can step outside the exam room and say, I want you to see my clinical pharmacist because you've got these 3 issues and you're on 10 different medicines, and we need to look at that more closely. But now he's got an expert team that can do that for him, and he's not having to spend a lot of that administrative time.
I love that. Like, I like the idea of partnering more with pharmacists, because sometimes you go to the pharmacy and you're like, I don't know what the doctor's doing. Like
right.
it's like a different world. You're like, I don't understand because I thought I went to the doctor, but that coordination saves a lot of times for patients too.
Saves a lot of time for patients, and they have another trusted partner in that practice that they become very attached to. And the clinical pharmacists love the work because
Mhm.
they also love working with physicians. They love working with patients directly and educating and trying to figure out problems, solve problems for patients. When you compare that to counting to 30 multiple times a day, all day long, it's a huge opportunity for clinical pharmacists to function at the top of their license because they're certainly much more qualified than just filling prescriptions. And so we've found that it's been very attractive to clinical pharmacists. So
I like that.
yeah.
I would love to hear more. You mentioned that you have a 45% reduction in, was it? Yeah. Was it? What was it?
Admissions in that population that we're intensively managing, we see a 45% decrease in hospital admissions.
That's big.
So
Um, Tell me more about that. Like, what does it mean when you have more coordination? What are there other outcomes that you've seen that are unusual or that people would notice?
yeah, I think the biggest thing for the model is that as we identify these patients through our technology, we realize that uh, all across the board, those that are sick and those that are considered to be relatively healthy, they all have what we call gaps in care. And so we have many, many of those that have not gotten their mammograms, that have not gotten their colonoscopies, that have not gotten their blood pressure checked, or if they've gotten it checked, have not gotten it under control. A lot of times we find it's because they've not gotten their prescriptions filled. They were either too expensive or they didn't have transportation to get to the pharmacy to get them filled, or the pharmacy, their prescriptions are on 10 medications and their prescriptions are out of sync. And so they're having to go to the pharmacy 2 times every week to get various prescriptions filled instead of just getting them all filled on the same day once a month. And so it's little things like that, transportation awareness, that really impedes a patient's ability to get good care. Once they start getting that good care and getting those things done, they feel better and they're more active and they're doing things. They're more likely to follow up on the doctor's recommendations when they know they've got that help and support.
Yeah.
So,
When you look at this through your lens of population health, what are the changes that stand out the most?
so I think over the years, it's become more and more recognized how important social determinants of health is to overall outcomes. The office practice and decision making there is obviously extremely important. The decision making of the specialist is extremely important, but that overlay of their social situations and their social determinants, where they live, what street they live on, whether their streets are safe, whether they have transportation in those areas to get to the grocery store, whether they have food deserts or not. All of that plays such a huge part in patient outcomes. And in one of my previous roles, we actually mapped that out across the
Oh,
geographies and
wow.
area, and you could identify that here's an underserved area, and you could tell that the outcomes and the quality outcomes in that area were much lower than in other areas. And so intervening with community health workers, who I think is going to be one of the workforces of the future, uh, made a huge difference. Somebody in that community who's recognized that community as being someone like them, depending on their nationality, et cetera, that can communicate, we can train, that can communicate with them, make sure they're getting to the doctor, making sure they're getting food, making sure they're getting their medications. That end of the spectrum from healthcare years ago had been totally ignored. And this is evolving as becoming probably the single biggest benefit of population health.
Yeah. I That is important. Like if you go to an area where they don't trust you,
Right.
you're not really going to be able to get a lot of traction there.
That's exactly right. We've had areas, populated areas where the culture there was that they didn't trust anybody unless they knew them, unless they lived in that
Like that
community.
they didn't trust anybody. It's not just
Yeah, don't
it's not
trust
just
anybody.
physicians. I feel like I know these people.
That's right. So,
Yeah, like you have to have that foundation where they know you care about them. You talked about how that will be a bigger part of the future, and I like the predictions people make. Like, so what other changes do you see?
so I think the biggest change is going to be creating the technology that, so you can't do without the people. There's always got to be people there that are driving, those
No healthcare without people. Classic.
healthcare without people. Yeah. But I think one of the biggest changes is as we develop the technology that connects all of that connects the primary care doc to the specialty care to their own community and their social determinant needs that are specific to their communities. Right now, that is so fragmented that it really takes a huge lift, a lot of investment, and a lot of various technologies to pull all that together. That has to be solved. And as that's solved, you're going to see healthcare improve related to that integration, as I'll call it, across all these pieces.
So you expect it to improve? This is in writing. This is official on the record.
I do expect it to improve. I think it's going to be slow, and I think Medicare is going to play a big factor in this because they control such a huge percent of the population, and so and Medicare is making efforts to move in those directions, and they're trying to figure out how to enhance and facilitate incentives around moving in that direction. But then I think it's going to take private equity, it's going to take businesses to understand that there's a business opportunity here for them to create that technology. And as the payment models change and begin to influence businesses to create that technology, then I think we'll slowly see that accomplished. But it's not going to be in the next year or two. It's not going to be tomorrow. It's not going to be tomorrow. It'll be the next decade.
You said it would take private equity. I've heard a lot about these partnerships with public-private investment government. Everybody thinks that the part that they are already part of should be the one that kind of saves everything. Why is that?
Well, I think, again, it goes back to the same conversation I had about the practices and the delivery systems not having enough cash reserves to make the right investments. Governments don't, at least local governments don't either. So you think about a local city, county government. Many of those people recognize the issues within their communities, but getting enough money and being able to hire the expertise to fix those problems is problematic. And so partnering with a private company that can come in and help, even if on their part it's part of a R&D effort, to see, is this problem solvable? How is it solvable? Can we partner to a private-public partnership to try to figure out what the issues are, how to identify them, how to fix them? I think it's going to take that and the private equities expertise and money to help solve those problems.
Yeah, that's a great perspective. I hadn't really considered that. Like floating that is a huge endeavor, especially for government. We're almost out of time, even though after this we do have a roundtable. So I hope everyone listening now will come and we can have live questions if you want to know more. I would love, in closing, for you to tell me what you would tell a health system leader. You said that the process will improve, but it'll be slow. What do health system leaders need to do, and what can they do to speed it up?
So health system leaders have got to view this as a very strategic process. And it it is, in my opinion, in their best interest to be investing in this now, because as Medicare moves more and more into alternative payment models, and they're committed that by 2030, all of Medicare will be in some type of alternative payment model.
Huge.
And delivery systems, to be successful at those things, it's not something that on Friday afternoon you meet in corporate and say, we're going to become proficient in alternative payment models, and then Monday you wake up and you're proficient in alternative payment models. It takes a decade to build the infrastructure, to gain the experience, et cetera, et cetera. And so if you're not at least moving into that market today, you're going to be caught behind when all of a sudden it hits. And there are lots of private equity companies out there that are rapidly getting into that space. And so delivery systems have either got to figure out how to partner with somebody like that or do it on their own. And if they're going to do it on their own, they need to get started now, because in 10 years, it'll be too late.
Right. So, that's a lot of fancy math.
Yeah.
I wanted to thank you for your time today and for your expertise in sharing it. And I think it's amazing that you've created a system, or Upstream has, that allows physicians, clinicians, nurses to see the benefit, to be rewarded for improving patient health, and to work in partnership more.
The one thing we did not talk about and didn't emphasize is the fact that within that model, as opposed to waiting 8 or 9 months after the end of the year, we're actually paying our doctors based on their quality scores every month. And as
every month, that's huge.
Every month. And so as their quality scores improve over the course of the year, we pay them more every month based on their quality scores that our teams are driving for them. So our teams are closing those gaps and driving their quality outcomes. And so for a doc, it's real-time incentive. I can see that I'm improving my patient's care, I'm improving their quality outcomes, and I'm seeing a financial reward for it immediately, not 18 months from now. So
that means you have to be able to show it to them right now.
Got to show it to them right now. Got to have the technology and the outcomes right now. Right.
So that is a huge technological endeavor that you just threw in there. Like, show them now. Like, okay, well, that seems easy.
Yeah. Well, like I said, the EMRs won't do it, but our systems will do that. So
I hope more people can learn about that, and everyone will come to hear you at the live Q&A. And if you have any questions, you can reach out. We'll have the contact information for Upstream. And thank you so much for coming today and for having this conversation about value-based care that is still around.
Yeah, you're still around. Oh, thank you. I appreciate the time. I enjoyed it.
Thank you.